Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Catherine Berg.
Pediatric orthopedics differs from adult orthopedics because it must account for growing bones, growing joints, and growing muscles, which behave very differently than those of adults. We're going to talk about the treatments of scoliosis, also hip disorders and foot disorders, and some complexities that come with both of those. This evening's program is underwritten by the El Paso Children's Hospital, and we also want to say thank you to the El Paso County Medical Society for bringing this program to you for over 28 years. I'm Catherine Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Thanks for joining us. We're going to be talking about pediatric orthopedic surgery today, and we are with the El Paso Children's Hospital, and there are orthopedics all over the place. We get that. And before the program, we were talking about pediatric orthopedics is a very finite specialty because there's a lot of growing things happening within the bones, and you can't just go and repair without having the idea of growth plates and everything else involved in that. So we have two individuals with us, and thank you so much for coming to El Paso, number one. We have Dr. Marcella Woiczik, and Dr. Marcella Woiczik says people just don't even say Woiczik, and it's the beautiful spelling of Woiczik. So I am going to honor you all night long and call you Dr. Woiczik because it's a thing. She is a board-certified orthopedic surgeon and hip specialist, and again, pediatric specialist, and she's with Texas Tech Physicians of El Paso. And then we have Dr. John Heflin, who is also a board-certified pediatric orthopedic surgeon, and you specialize in spines. Yep. So this is going to be great. We've been doing this show for years, and I sit crooked, I walk crooked. I am a scoliosis girl, so I am looking forward to learning a lot from you all this evening. Now that we've introduced you, I would love for you to take just a couple of minutes and tell us, and Dr. Heflin, we're going to start with you, because Dr. Woiczik just said, you know, this is not something that I do and I'm good at doing. Let me break the news to you. No one's good at doing this. And being on TV is not fun because it makes you nervous. So please know that all of us are in that same boat. And because you didn't say you were nervous, you get to go first. Isn't that great? So tell us why you came to El Paso, and also with you specializing in pediatric spine surgeries. Tell us what it is that you do all day, every day. And Dr. Woiczik, we're going to do the same thing with you in just a moment. So it's your floor.
Great. Okay. Well, we'll talk about what I do. How about that? That'll make it a little easier to understand why I came here in the first place.
Okay.
So I take care of children, just like Dr. Woiczik does. We focus in a little bit different areas. We both take care of common everyday stuff, fractures, lumps and bumps, sprains, and that sort of thing. I have a focus in spinal disorders, so that would include deformity of the spine, which would be like scoliosis and kyphosis, but also in instability issues like spondylolisthesis. We were talking about mouthful. That's a mouthful. But spinal fractures, back pain. So basically anything involved in the spine.
Okay.
And I've been doing spine specific work now for about 10 years. And what brought me to El Paso was the understanding that the spine coverage was going to go away with the retirement of some of the local physicians. Everybody has a career and everybody ends their career ultimately. And so in looking around the country at different opportunities, and we'll get back to what that means here in a second. El Paso came up as a possibility via one of our previous trainees from my program at the University of Utah. We had trained a person there, and they had come down here and had established a practice here, and we had been in contact, and it came up that there was possibility of a need, and the need was apparently pretty great, or forecasted to be, and it seemed like a good opportunity to come down and provide something to the community that it might have had but would be losing in the near future. And so that's kind of how I got here.
Okay.
I started at started my orthopedic career really at the University of Utah. That's where I've been for the last many years, and for many reasons, it was time to move on to a different opportunity, and this presented itself, and so that's how I got here.
We really know why it is that there's no place like El Paso for Mexican food, and I think many doctors move here because of that. Could that be one of the reasons?
That's it, and also the fact I think tequila was developed here.
Tequila was developed here, exactly. We need to take you to Paso Norte. There are so many reasons. No, but I'm glad to hear that, and that is something too that we joke about it, but at the same time, El Paso is such a community that you don't respect or know about until you actually get here and live here for a little bit. And then you're like, wow, this place is great.
We had actually had some involvement with El Paso with outreach through Shriner's program years ago. And so we had been down here before, Marcella much more than myself, but we knew a little bit about the town and the friendliness of the people. And so we were at least somewhat aware of what we were getting ourselves into. So.
What a perfect transition, Dr. Woiczik. How do you do? So what brought you here? So you've been here a couple of times before, and kind of lead that same line of question.
So I think I'll start a little bit more with background.
Okay.
I started my job in pediatric orthopedics in 2007. So I did my training up in Utah, and my training was combined at the University of Utah and Shriners Hospital for Children. In my role there, we would come to El Paso and cross over into Juarez. For my first 10 years in practice, we did that 4 times a year.
4 times a year. Nice. Thank you for doing that.
And it was one of the highlights of my career. It was, we transitioned to seeing patients in El Paso solely a couple of years ago, I think, when the climate changed a little bit socially. And then we started seeing patients just in a clinic nearby. And our interaction with the community was really eye-opening and I think really just enjoyable for me in a different way than taking care of patients in an everyday clinic. The patients that we took care of were incredibly grateful, didn't have great access for care. And we really lost a little bit of that interaction when COVID happened. And we stopped being able to come down the way we used to. And many other things changed with our practices where we were, where it was less of a community feel. It was a little bit more cutthroat academic environment. And so as lives have changed and people have changed their focus, I think even since COVID, the things that have become important are working with people that are a team and working with people who want to take care of each other and take care of the people in their community, which isn't something I had in my last job. So we were looking for opportunities. We both have worked together for a number of years. But there's a surgeon here in town, Esteban Garcia, who I had the opportunity to train when he was a resident with me and a fellow with me. And he is someone who's been here in the community for many, many years. And he said, we'd really like to help grow the pediatric orthopedic climate here. There's been a couple of fabulous surgeons here that have been around for a long time, and I think at some point they will end their career. And this allowed us the opportunity to bring a little bit of youngness to it and a little bit of more comprehensive nature to the community. I've been in practice now for 18 years. And I have a certain skill set. John has a certain skill set. Our other partner, Esteban, has a certain skill set. We have 2 nurse practitioners that we're now working with, and we have a new, I think, enriched team that is really excited to work together and grow something. And just in the few weeks I've been here, the community is incredibly grateful in a way that I haven't had an opportunity to experience in years.
There is no one like an El Pasoan. You know, there is just a way that just being here just invites gratitude, invites warmness, invites family. Thank you so much for coming to El Paso. We appreciate that very much, and I hope that you fall in love with the city as much as I have. We were talking about a team earlier, and you said that you have about 5 people right now on your team that brings the team approach. I volunteer for this program. I work with the El Paso Community Foundation, and just yesterday we had UNICEF here. El Paso, America is not really UNICEF happy, but we are trying to bring specialties of pediatric medicine to El Paso. Right now, the pediatricians are at a good number just because we're having less and less babies. However, we don't have a lot of pediatric specialists. So praise and adoration to El Paso Children's for doing that and bringing you all in and for helping our community. So I just wanted to put out there that first. Dr. Heflin, I would like to talk about something that we hear a lot about, which is scoliosis. And if anyone's, and I don't know if they do it boys, but I remember when we were kids in school and right around the time when you'd start menstruating, everybody would go to the nurse's office and you'd bend over in front of her and they'd feel your spine, and some kids got set to one side, some other. And I was one of the ones that were set aside. I have a nice crooked spine. But talk about scoliosis. How common is it? But then how and when is it an issue enough to get some kind of treatment for it? And I think that's probably where I'm going. It's like, where is it? Like, I haven't ever had treatment. As I age, my collarbones are not even. There's a lot of things going on, but it's never been, it's chronic but benign. And maybe explain where that becomes not benign anymore.
Sure. Well, I think you have to understand what scoliosis is to understand, what we've been talking about, really. For most of my medical colleagues, they'll know that scoliosis is represented by a picture on an X-ray where the spine's crooked, right? I think what most people don't recognize is that scoliosis is actually a 3-plane deformity where the spine, the traditional curve that you see in the spine is what we call the coronal plane, is just one part of the actual deformity in which the spine is actually producing a helix. And so if you look at the spine from the side, it looks like this. If you look at it from the front, straight. But what's happening is the spine is twisting as you grow. And so it's really a helical deformity that we're looking at. And the X-rays that we take are really just an estimation of how much that curve is changing over time. So, so scoliosis itself is relatively common. It varies across the world, and it's certainly more common in girls than boys. For small curves, it shows up in 1 or 2% of the population. It's about twice as common in girls as boys. As the curves get larger, they become more common in girls. So curves in the 25, 30 degree range end up being 4 times more common in girls. And then surgical.
And why is that?
No one really knows.
Okay.
It's probably has something to do with the rate of growth and the hormone milieu that that girls have that boys don't. But no one really knows. But what we do know about scoliosis is that the bones themselves should grow straight, right? Most of our bones do. There are bones that don't. The femur doesn't grow straight. It twists. The tibias twist. The humerus twists. But the spine bones are not supposed to twist. They're supposed to grow straight. But if you think of each one of these little spine bones as like a little tuna can, the lids are going in different directions as it grows at each level. And so what people mistake as a soft tissue disorder, they're like, well, I can send to the chiropractor and try to stretch out the muscles. It doesn't work because fundamentally it's the bones that are having a problem, as is most of what we do. They're bone-related issues. So as the bones twist as they grow, then the patient develops this helical deformity that we're talking about, which is why you see a rib prominence, because then as the spine twists, it twists up the chest, it twists and pushes up on the chest wall. And so what you see, what manifests when you did the Adams Ford bend test that you were talking about is a rib prominence. And so small curves don't matter.
Right, and that's the question.
So a 0 to 10 degree curve isn't even a curve. We don't call it scoliosis. Once you hit 11 degrees, the Scoliosis Research Society has defined that as scoliosis. And so from 11 to 25 degrees or so, that's considered a small curve. Small curves, by and large, are not problematic. And if you graduate from adolescence with a 25-degree curve, no problem. You'll be just fine. You can live your whole life with a 25-degree curve. The back tolerates small curves very well. I mean, we have natural curves that you see, right, that are more than 25 degrees in most cases. Curves between 26 and 45 degrees are considered a moderate size curve, and those curves are at risk of continuing to progress over the course of your lifetime, but typically not enough to warrant surgical intervention or stabilization. Curves greater than about 45 degrees have a tendency to progress throughout the course of your lifetime, likely just due to gravity.
And what are the issues that come with 45 plus? I mean, what kind of conditions, issues, aches, pains?
So curves over 45 degrees don't necessarily have to have an issue associated with them, but there is at least an increased risk of more rapid progression over the course of your lifetime. The larger the curve is at the time that you stop growing, the faster that curve will progress. And so curves of 55 degrees or so are thought to progress at somewhere between a half a degree and a degree per year every year, which is very difficult to measure from year to year.
Yeah.
But 30 years down the road, you know, a 55-degree curve may be an 85-degree curve. That is problematic. And so curves around 90 degrees or so are known to have physiologic consequences. So an increased risk of restrictive lung disease and pneumonias and things as you get to be older. There is an association with back pain once you get to curves greater than about 35 degrees or so. And so the larger the curve is, the more likely you are to have back pain. And some of the curves can be somewhat debilitating in their
So if we can explain to the audience, when you're talking about heart issues, for example, where does the spine play with having a heart issue? Is it the way that the spine is then coming into the cavity of the body, or the twist that you were talking about?
If it gets really big, it can cause cardiovascular problems. The biggest problem that spinal deformity causes really is pulmonary problems, so for respiratory type stuff. And so effectively what's happening is it's twisting the actual box that the lungs live in and making them smaller. But in addition to making them smaller, it's also making it stiffer. And so you get a combination of restrictive type component where the cavity that's available for lung expansion is small, but on top of that, it doesn't move very well either.
Okay.
And so the bigger that deformity gets, the more problematic that becomes. And so as you get into very, very large curves, 90 degrees, 100 degrees, whatever, you can have a very significant restrictive type lung disease.
So when does a Dr. Heflin come in and give some treatment? So I don't know if there's treatments other than surgically going in. I remember when I was in school, there was a girl that wore a brace, her curvature, and I didn't know if that was, again, I'm looking junior high, I'm thinking from 10 years old to 14 years old, and that's when growth spurts happen a lot with females. And we always were kind of, we thought it was just so exotic, like, okay, so what's happening? When do you manipulate the spine in whatever way you need to?
So I tell people that the management of scoliosis comes in three flavors. One is observation, which is the vast majority of what we do. So small curves we just watch, and they can be watched all the way through adolescence. And so any curve below 25 degrees, we generally are just keeping an eye on for the most part. If the patient is younger, we do consider the second form of treatment, which would be bracing, which is what you just discussed. Okay. There's many types of braces out there that we utilize. And bracing protocols are a moving target. They have been forever. We think we understand them until we really look at it, and then we don't. So there's a fairly comprehensive study done looking at bracing and how effective it is. That was done about 10 years ago, actually. And it turns out that with a well-made brace in a child who has a curve between 25 and 45 degrees, there's about a 75% chance of keeping them out of the OR if you
okay.
brace appropriately. Appropriately is 18 hours of wear per day. It's a lot of wear.
Yeah. And the ages, can you talk about when that would start?
Yeah, and so the ages in general are right at the beginning of adolescence. So for the most part, kids in the 11, 12-year-old range up to about skeletal maturity, which would be about 14, 15 years of age. So that's when you see most of the braces go on. Now we brace younger kids than that who show up with early onset scoliosis, and we don't brace kids older than that because it doesn't make sense. Scoliosis, if it's a growth-related phenomenon, you don't want to be bracing somebody 18 years old because they're not growing. So if somebody's putting a brace on a child that's 17, they're probably wasting everybody's time. And so we do utilize bracing. There are curves that are too big. There are curves that are too small. But recently, bracing protocols are now putting braces on children who have curves in the teens. So 15, 16, 18 degrees, using a brace that they wear at nighttime only. So just bending brace, it kind of twists you. And that's relatively new. We haven't been doing that routinely for a while. Day bracing generally doesn't start until you get into the 25-degree range or so, which is probably what you were familiar with. And then when you hit about 45 degrees, we've kind of all decided that bracing beyond that isn't going to save you from surgery. It might slow your progression so that the curve isn't as bad when you finally get surgery.
Right.
So we still use braces to try to kick the can down the road, so to speak. But even when bracing is done absolutely perfectly, kid wears it 18 hours a day, there's still a 25-30% chance that it's going to progress to surgery anyway.
So there's the next question. So now we're at a point where someone who is, let's say 18, 19, where the growing is done, and you, people in your position say, okay, let's try to do surgery to correct the spine. So physiologically, and we can use this guy. We were joking about trying to name him earlier. Just a nod to Dr. Cucchini, who used to call her spine guy Dr. Bonaparte or Mr. Bonaparte. But in general, when we're looking at the spine, you're talking about the twisting. Surgically, how would you go in and fix that? And I know there's twisting in different areas of the spine.
So the most common twist that you'll see in the spine is actually in the thoracic spine. So this is a spine model that shows the lumbar section down here, which is 5 segments. You've got your thoracic segment, which is 12, cervical up here. Now you're looking at the patient back to front, right? So this is the back looking this way. This is the same way I look at it back in surgery. The spine generally twists to this side, like this, through the thoracic spine, much like this. And so it's a twist to the side, and this is what leads to sort of the rib prominence. The reality is it actually kind of twists like this, but it's kind of hard to recreate. But anyways, it goes this way, but turns this way so that the ribs are coming out. The goal of surgery is to try to not only correct it in this plane right here, but to also create a normal roundness to the back, or a normal kyphosis, but also to derotate the spine to try to achieve a neutral rotation of the vertebral body. So it's actually a really complex reduction that we're trying to achieve, because we're trying to correct a 3-plane deformity. The way that's done is you essentially open the soft tissue so that you can see the back bones, and then we place screws into each of the bones so that we can control each bone that we're trying to correct. We don't want to fuse the entire spine because then it's very, very stiff and you can't move very well. Right. So we try to selectively fuse as little as we can to actually correct the deformity, and then but then prevent progression above or below, right? You got to be a little bit careful about fusing too small, because then you can end up with progression above or below. The screws are placed through these little columns of bone right here called pedicles, hence the name pedicle screw. So the pedicle screws will go into each of the vertebral bodies that we want to try to control, and then we bend our rods to look like the shape that we want the spine to be at the end of the case, sort of. And we do use some fancy bending to try to account for the deformity. And then we place the rods into the spine, and we attach the screws to the spine, or to the rods, and then we perform the correction. It happens in a pretty rapid sequence, actually. It's sort of remarkable.
So while doing that too, I'm trying to think about muscles and ligaments that are already trained just our bodies just naturally training themselves with muscle memory, et cetera. So when you're looking at now manipulating the way that the spine is, now that it's straight, you may have some muscles that have been for their entire lifetime a certain way. How does the recovery of this type of surgery occur with physical therapy? Obviously, maybe the stretching of the muscles.
Yeah, it's a very rapid process. You push it really hard, really fast, and it's essentially a kind of just a brute force effort, and you get it as straight as you can. Interestingly, over the next day or so, the patient's shape of the back will continue to change as the metal tries to get back to its bent shape, pre-bent shape, right? So when we put the rods in, it actually will change the shape of the metal, much like a spring. And then as the patient lies in bed, the viscoelasticity of the tissues will allow the rods to continue to change shape over the next several days while the patient is. So the patient's back will actually look different a couple of days after surgery, which is why taking an immediate film after surgery doesn't make a ton of sense, because the back's going to look different a few days later.
Right.
Because
the body is trying to work itself into that.
Yeah,
positioning now.
the tissues are responding to the metal as the metal tries to recover its shape. Because of the metals that we use are very tough, and they try to get back to the shape that they were in when they were placed. And so at some point, the forces in the spine and the forces in the metal are equal to one another, and everything stops.
They get to be friends.
And at that point, then the fusion occurs. And a lot of people think that the metal is the fusion, but the fusion is actually bones healing to bones. And so the rods and screws are a brace. It's temporary. We scuff up the bones with a little drill, little burr, and bone's not very smart. It knows how to do one thing, and that's make bone, right? So if it gets infected, it makes bone. If it gets cancer, it makes bone. If you scratch it up, it makes bone. So we scuff it all up, and it starts to create bone to try to heal, because that's what it knows how to do. And it will heal level to level because those bones are held static. And so the bone kind of just grow over each spine, each vertebral body, ultimately turning that section into a single bone.
Wow.
So that's what the fusion is. And once there's one chunk of bone right there, then they can no longer deform anymore. Right. And the power of the pedicle screws is that they can actually overpower the growth potential of the bones. And so once we place all that, it's pretty well locked into place. Years ago, we would fuse it from the back using a set of rods and some wires, but then the front of the spine would continue to grow while the back of the spine was held.
Oh, interesting.
And so the spine would actually spin around itself.
Okay.
It's called crankshaft deformity, and it was a horrible problem when it happened. So the instrumentation we have now is extremely powerful and will actually shut down that growth. So wherever we put it is generally where it stays. So it's hopefully a one and done type procedure.
It's interesting how you put that together. And I'm just thinking to myself, off subject, but sort of on, when you said bone knows how to do one thing, it makes more bone. I've always been curious about bone spurs. I know it's kind of off topic, but you could probably answer that in a minute or two. Like a bone spur occurs when? I know somehow there's some kind of trauma to the bone. The bone wants to, I guess, fix itself. Is that where the spurs come in? And then it goes into nerves? Because I have a little bit on me too. So whoever wants to answer that, that's just a curiosity. Dr.
It's
Woiczik?
usually a reactive process.
Okay.
So I think if a bone gets injured or recognizes that something's happened to it, it wants to try to heal itself. And so then you can get a bone spur. And sometimes they're helpful, and sometimes they get in the way.
Mine's in the way. Should I have it removed?
Depends where it is.
It's right at my neck. Right, I can't turn this way.
Yeah.
Then maybe I should. I'll come see you guys. I'm not a pediatric anymore, but this is a nice transition. Dr. Woiczik, I'd love to talk about hip disorders. So there are hip disorders, and then there are complexities that go with them. Some are common, some are not. So I'd like for you to maybe start with what are some of the most common hip disorders that might be a problem but relatively benign, going into hip disorders where really it is impeding movement and walking, etc.
So there's a couple of things that we see with some frequency. One of the most common things I see and treat is hip dysplasia. And hip dysplasia really has two different varieties, so to speak. The first is something that you're born with.
Okay.
And so that used to be called congenital hip dysplasia, but more commonly it's now called developmental dysplasia of the hip. And that's usually a child that's born with some abnormalities in their hip, some instability in their hip. And there are some risk factors that occurs in. And then there's a second type of hip dysplasia that happens in patients who have neuromuscular disease, conditions like cerebral palsy, spina bifida, other syndromes. And the two entities don't behave the same. If you're born with hip dysplasia, we typically see it more in girls, similar to scoliosis. We also see it associated with children who are breech in utero, in patients who have a family history. And those are some of the most typical risk factors that we see it in. And so I think in the community, and even in the practitioners we've met with in the last few weeks, they really know when to screen a child for hip dysplasia. And so if you have a firstborn child that's female that was breech in utero and maybe there's a family history, they typically will get an ultrasound to assess their hip development at roughly 4 to 6 weeks of age.
Okay.
And treatments will be determined based on what the ultrasound and the exam findings are. And that's a condition that you can monitor throughout growth, just like scoliosis. It can change as you grow. Neuromuscular hip disorders, hip dysplasia, usually is something that develops as the child is impacted by their neuromuscular condition. Cerebral palsy, for example, is a condition that has muscle spasticity most commonly. And the muscle forces being spastic or tight can affect the hip development, which can make the hips over time subluxate or dislocate and come out of the hip socket.
Oh my, okay.
And the identification of those is a little bit older, maybe age 3, maybe age 5. And some of it depends on the complexity and the diagnosis that the patient actually has. When children are more functional and more ambulatory, they have less issue with hip dysplasia in neuromuscular conditions, whereas children who are wheelchair bound and aren't standing and walking routinely, they'll have more significant deformity that needs to be treated.
So treated. That's the question now, because I can see two almost very different types of treatment depending on how their lifespan is going to carry them. If wheelchair bound is one issue versus being mobile is another. Take whichever case study you would like and go into how, and let's take someone who is not in a wheelchair, someone who is mobile, but is having a difficult time moving around. How would you go in? And again, I always think to myself, growing bones is such a thing. You can't just go in and fix it and let it be because there's stuff still happening in there. How do you do that? Like, how do you work that through?
So the approach is different based on what's going on with the patient. The child who's born with hip dysplasia has a very different treatment algorithm than the patient who has a neuromuscular condition. Probably more commonly, we see children with I'll say run-of-the-mill hip dysplasia where they're born with some hip instability. In those patients, if you meet them at 5 or 6 weeks of age and they have some hip instability or immaturity, we'll place them in a Pavlik harness.
In a pelvic harness?
Pavlik harness.
Okay, tell me what that is.
It's a brace that is soft and Velcro-y. So, and the pictures of this device show the baby always smiling. It takes a few days for the baby to accommodate to it, but it's a brace that goes around their chest. There's 2 straps. It's kind of like a book bag almost. And then there's 2 straps that hold the legs up and out, which I describe to patients as the frog position. So you don't want the legs to stay together. You want the legs to be separate. And what that does, it allows the ball to be in the hip socket and have their best chance to develop. There are different positions that the hip can be in where it's less optimally developing if the legs are together. So the hips flexed and out is how we typically treat them in a harness.
And how often are they in this harness, or how many hours a day, I guess, would be the question.
It's on full time.
It's full time.
It's at least 23 hours a day. So usually I tell parents, the more it's on, the faster it comes off.
Okay.
Take it off for a bath, and not every baby gets a bath every day. But some of the amount of time in the harness depends on the severity of the dysplasia. If it's mild, sometimes you can take it off sooner. If it's more severe, where the baby presents with a dislocated hip and it's not in the socket, the treatment is a little bit longer and potentially for more months than what you might typically see.
Okay. So we're talking months at a time. We're talking.
Yeah. Most kids need a pelvic harness for 3 months.
Okay.
There's some full-time wear, which is that 23-hour time, and then there's some weaning wear. And for most children, that harness is successful. It has a success rate of over 90% for typical hip dysplasia. If I meet a baby with a dislocated hip, the success rate goes down to 60 to 80% with that brace.
And when you say baby, we're talking brand new out of the gate baby?
5 to 6 weeks of age.
5 to 6 weeks of age, you said that earlier.
Yeah.
Okay.
So for the babies who don't, where the pelvic harness isn't effective, we have some other braces we can try, but sometimes those kids need surgery. You asked earlier about, what their function would be, and the interesting thing about this diagnosis is children are going to reach milestones when they reach milestones. They're going to sit on time. They're going to crawl for the most part. They'll stand in cruise furniture. They'll walk on time with a dislocated hip. It doesn't hurt. It is often missed. And
really?
So we'll sometimes
it doesn't
see,
hurt. It is often missed.
Yeah.
Interesting.
So sometimes we'll have a child come in at the age of 2, and someone in preschool or a family member will say, "Why is your son walking on their tiptoe? Why does one leg look a different length?" And if both hips are dislocated, they often have a waddling gait. And sometimes it's really subtle and it's hard to pick up. And those kids will for sure need surgery. They don't get a pelvic harness.
So here's it might be a difficult question. If, and I'm thinking if you have your well baby checks, you have your yearly checkups after a certain year, do doctors know, just general pediatricians know to look for this? I'm trying to figure out how to ask this question. How would a parent know to look for this if they do not notice? Like you said, it could be very benign. You don't really see it happening.
I don't know that parents would know to look for it. I think pediatricians are trained to look for it based on the risk factors we talked about. But quite frankly, sometimes it gets missed. If you live in many European countries, kids get screened universally for this. In the United States, we screen based on risk factors, so not every child gets an ultrasound. But it gets missed. If it gets missed and we pick it up under the age of 4, they have a very good chance of having it fixed successfully and having a normal, healthy hip for the rest of their life. The later you are when we pick it up, the options change of what you can do, and the outcome becomes a little bit less certain. So we definitely try to find these and fix them young. The remodeling potential of the hip joint is best under the age of 4. It can still remodel and grow and change up until the age of 8 and even older.
So here I'm trying to think about materials being used. So are we looking at just, again, physiologically, is it just bones that you're using? Is there any outside material brought in? Because I'm just thinking about growing. When you're putting something in place, the child's going to outgrow whatever is being put into place. How does that factor in?
So if you're asking about surgical correction.
I am, yeah, so I should have brought that up, yeah.
For a dislocated hip, a lot of what we do is just change their anatomy. So there's not necessarily putting anything in like you would do in an adult.
Okay.
In adults, you might put in a fake hip component.
Right,
As we get older, we get arthritis and you can do a hip replacement. Our goal is to avoid that in a little kid, to let the hip grow as best as it can. So putting a hip in requires training and skill to understand the procedure to place the hip back in the normal hip joint. And then there's some augmentation procedures to either the femur bone, the thigh bone, or the pelvis bone above it, which is the roof that covers the ball. And sometimes there's some graft, but there's typically not a lot of implantation or technique to do it that.
Okay.
And then we place patients in this really fabulous spica cast that most parents hate, which is a body cast. And that's on for roughly 3 months.
A body cast.
Yeah, which is just what every 2-year-old child
Yes,
wants.
yeah. So. A lot of screaming, I'd imagine, wiggling around. And you're giggling, not in a knowing way, I should say. Because I do want to continue. You have something to say, so I want you to add to that. And then I want to talk about feet, too, because I want to talk about clubfoot.
No, the spica casts are,
You want to describe what they look like? I mean, when you
Well,
say
they
full
look
body.
like fiberglass pants. I mean, more or less.
Okay.
So the kid's stuck in a frog position that she just described in the padlock harness, but made of fiberglass. And so you can imagine something that wraps around your entire child's body, and there's peeing and pooping and other good times. For parents, it is quite an experience for sure. You know, very effective at what it does, but it's.
So I'm thinking of this, and we're talking about how difficult it is, but let's talk about the success of this going forward, which you had talked about too. So for the most part, there's a high percentage where the hips will then develop normally, for the lack of a better word.
Correct.
So there is a fine reasoning to this. There's what is it called? Short time pain for long-term gain.
Correct.
So I'd like to transition really quick because this is fascinating. I'd like to talk about foot disorders and what is commonly called clubfoot. If you can describe what that is, either one of you can take that. I don't know who is.
That is her
more.
baby.
Okay. Oh, right. There you go.
Yeah.
Okay. So how would you describe to the audience, first of all, what's it called? Again, we call it clubfoot. And what is happening in the bones of the foot with that condition?
So a clubfoot has a fancy medical term called congenital, meaning you're born with it. Talipes, which means foot. Equinovarus means the shape and the position of the foot. We call it a clubfoot. I try to describe to parents the first time I meet them that I think it's mostly that the foot looks like a golf club. The foot is down and in, and it looks just like a putter or a small driver of a golf club. But it's fixed. It's not something that if you look at the foot, you can just quickly stretch it out and it'll look like a normal foot. But again, similar to hip dysplasia, there's really two types of club feet. There's an idiopathic clubfoot, which is the run-of-the-mill clubfoot, where there may be a family history. Sometimes it's the first child in the family who has a clubfoot. It's a little bit more frequently seen in boys. We don't exactly know why it occurs, a little bit like scoliosis. We know that there's some genetic component to it, but we have not figured it out. But the baby is often found to have a clubfoot in utero at their 20-week ultrasound. So sometimes I now meet parents with a baby inside that will discuss treatment. But those are the most...
And can you do treatment?
Not in utero,
Okay,
but we
okay.
just discuss what's going to happen after the baby's
Right away.
born.
Okay.
And then there's a non-idiopathic clubfoot. The other medical term for that is a teratologic clubfoot. And those are club feet associated with other things: spina bifida, arthrogryposis, other syndromes, neuromuscular conditions, similar to hip dysplasia. The treatments are similar, but again, different based on what the driving causes are. For a typical clubfoot, which I took care of a couple of patients with today, we do stretching casts. So we start that roughly at about 3 or 4 weeks of age. I do have patients who come to me after where the baby's a week old. I try not to do that because I want the baby to go home and bond with their parents and vice versa.
Yeah.
There's no benefit to casting right away after the baby's born. But we do a series of casts. They happen every week. And the casting technique was designed by a man named Ignacio Poncetti, who I met in 2010. He was still working at the age of 94.
Oh, way to go.
But he learned how to cast club feet and to manipulate the feet instead of doing surgery on feet. And you can correct the foot each week. And at the end of the casting process, you typically get a well-corrected foot. Most babies need to have their Achilles tendon stretched or lengthened because the foot doesn't want to quite get down to the floor. And the only way to do that is to lengthen the tendon. But they recover from it beautifully, and it doesn't leave a long-term
And how is
problem
that
with it.
done? How do they lengthen the Achilles tendon?
We cut it.
Okay. Well, this is a medical show,
Yes.
so that's what you need to do. Yeah.
So we cut it with local anesthesia. They don't have a general anesthetic or go to sleep, but it's a tiny little incision to stretch the tendon.
Okay.
And
and
in
it
my
has
mind,
that healing process on its own.
Yep, it heals
okay.
within 3 weeks.
Okay.
And then the foot is corrected. But like any growing child, the foot likes to come back, especially something that they're born with. So they get braces. And this is the hard part, I think, for the family. The bracing protocol is for 4 years. So for the first 3 months, they're in the braces pretty much 23 hours a day. And then they wean the braces so that when they're at walking age around 1 year, they wear the braces at night. Okay. And we do that because we found that the foot turns back in and reforms the deformity if you stop bracing under the age of 4. Okay. After 4, the likelihood that it will come back is lower. It's still possible. Okay. But if you can get
so there's the weaning really doesn't happen other than wearing it at night versus 24/7. Okay. Yeah.
And then, if parents are diligent with the braces, which is like really the biggest success, the child usually has a healthy, pretty darn normal foot that they can run, play soccer, football with, and they do really well. We used to operate on club feet and we don't anymore.
And this gentleman who was functioning and still going to work at 94 years old, how did he, and the reason I'm asking this, I'm just trying to think of the idea of, was surgery an option earlier, but now the bracing is really proving to be the best thing going forward. When there were surgeries, and I'm assuming every now and again there probably still are, if it's not caught on time, if, I don't know.
So the history of Dr. Ponsetti, I may not be 100% accurate, but Dr. Ponsetti was from Italy. He came to the United States and he worked in Iowa. And he felt passionately that club feet didn't need surgery because we found that the more surgery we did on club feet as adults, you have stiff feet, they have arthritis, they don't work very well, they hurt, and they're what you stand and walk on all day long. So he started casting and presented us as pediatric orthopedists with 50 years of data showing we can correct these feet without surgery. When I was a resident between the years of 2002 and 2007, there was some casting happening in this country, but a lot of surgery was still done. When I started my practice in 2008, we stopped operating on children with club feet and we started casting them. And that is now the standard across the world.
So say you don't get someone, depending on where you are culturally in life, socioeconomic situations whatsoever, and you find someone who is 2 years old.
You still try to cast.
You'd still try to cast. So that's still the standard, the gold standard way of treating at this point.
You may still have to do some surgery.
Okay.
But the surgery that was previously described is a really big surgery where you stretch a lot of things, try to move the bones into different positions. And again, it's very, it develops a lot of scar tissue and it becomes a stiff, small foot. If we have to do surgery for a club foot in an older child who is missed, we try to do very little to the foot to get it to what we describe as a plantigrade foot position, where the foot's on the ground and it functions like foot.
Okay.
So less is more.
So little bones are when we say little bones, not like just size little bit, but young bones.
Amazing,
are amazingly plastic and will respond to forces that are applied to them, which was the whole point of the Ponsetti casting. We use the same principle in infantile scoliosis. So we do see kids that are born with idiopathic scoliosis that will show up to clinic with 40, 50, 60 degree curves, and they're 1 year to 2 years old. Interestingly enough, using the same principles, you can cast a spine for a really young kid. And so we can actually have a fairly high success rate of curing scoliosis in the young child because of the plasticity of the bones. And so I do occasionally this process called EDF casting. About the same time Ponsetti was doing his casting, a lady named Meta was doing her casting on the spine and demonstrated very similar results. Very, very high success rates in casting.
So we're talking about a full body cast here as well?
This is truly a full body cast that is
it goes
shaped
from here to here.
Yeah, it's
I'm not sure which one's worse.
They're both horrible.
His cast or mine.
Yeah, but we provide a bending and a derotational and extension sort of set of forces to the spine, and the success rate for idiopathic infantile scoliosis caught between 1 and 2 years of age with curves less than 60 degrees is approaching 90%.
So here's that question again too. Unless you know what to look for, is it something that you can kind of spot? I'm trying to think you probably could with a certain
infantile
degree,
scoliosis
right?
is a lot easier to pick up on. I mean, the kids look like
you can tell that there's
a kid with a 40 degree curve looks like a little tiny banana.
Okay.
So so they're a lot easier to pick up on. But you'd be surprised at how many people show up to clinic with their 12-year-old
Yeah.
13-year-old girl, and it's like, I had no idea.
Of course, yeah.
You know,
and we
'cause-
hear stories like that all the time. We are kind of at a like the 7-minute mark. This happens so fast. We think, oh my gosh, there's a whole hour to talk about. But I'd like to kind of stop and see if there's anything that either one of you wanted to talk about this evening while you have the chance to do so. I know that we covered, like the big thing was covering spine, scoliosis, hips, and then foot. Is there anything else that you want to cover this evening while we have this time? I always think about what's new on the horizon. You know, what is new on the horizon with spines? And this is me being selfish as a 58-year-old. It's like, I know that I can feel it and see it every year. I can see it in photographs with a necklace that I wear, that the necklace is starting to do this. What do we see in the future of treating spines? I mean, I'm okay now, have been for a long time, but there's still worry.
Well, it depends. I mean, I think for the adult that has scoliosis, I think the standard of care is probably going to be what we call segmental instrumented fusion, which is what I do now. The surgery's a lot better, the surgical technique's a lot better, the outcome's a lot better. So I think that's where we are currently. And I mean, there's been some people who have tried using tethering techniques where they put screws in from the side and they put a cord and then try to push it across. The problem is that the deformity has already formed. And so that tethering process, unless the spine changes its shape, ultimately that material will fail. And so that's the problem.
I'm just
with
thinking
it.
the muscle memory of your 58 years worth of being.
Well,
in
the
that
bone
position.
shape, the muscle memory, just all the tissue tension that has developed over time. I don't know that there's a lot of strong science to support that that's going to work out long term.
Yeah.
There's people trying different versions of that to see if it works. I'm having a hard time wrapping my head around the science there myself, and I think a lot of us sort of struggle with that. But at least they're trying and thinking outside the box a little bit. I think the long-term goal, probably for club feet and for scoliosis and many of these disorders, is understanding the genetics.
Right.
And trying
In fact, Dr. Woiczik, I was going to ask about that. Yeah. We had a geneticist here a couple of weeks back, and it was just interesting understanding the genetics, but then being able to manipulate what you can manipulate. And she was talking about, I can't remember exactly what the wording was, but being able to manipulate, and or if you're looking at the parents of what traits may carry down, how is genetics right now working in your practice?
I think that in many circumstances, we're working in concert with genetics team to understand the genetics, what a specific diagnosis is. We've come very far with the number of genetic diagnoses we see. I think specific to some of the things that I'm treating, I think we definitely still have a ways to go to understand what happens to children and why. There are other hip conditions that we treat. One is called Perthes. We don't really know why that happens.
Explain what that is, if you don't mind.
It's a change in the blood supply to the proximal femur, the hip joint.
Yeah.
And it usually happens mid-first decade, so around 4 to 7 or 8 years of age. But we have tried for years to understand why that develops. We still don't know. There's a lot of theory. Same thing with club feet. We don't really know why somebody gets a club foot. And I think while genetics has shown us a lot of promise, there's still plenty of things we don't fully understand. And I think that's one of the beauties of partly why we're here is we have some really vast experience. I'm a very humble person, but I will say 18 years of working in an academic center, I've learned some things that I think we're really excited to bring here to El Paso. That patients have been leaving El Paso to seek care elsewhere. And, I'm colleagues with providers in Dallas at Texas Scottish Rite, with folks at Rady Children's. So we're here and we want to encourage families to come see us if they have a worry or a concern.
And that's what I love about this community. And little by little, and Children's has been very good about bringing in specialists. And on that note, I know that we are kind of an isolated community. So we have people coming in, Las Cruces, Deming, in the trauma field. Obviously, UMC is trauma level 1. But thank you so much for being here. We have literally like 3 minutes to talk. Is there anything else that you want to add? If not, I'll just kind of do a plug of how people can watch the show again. Or any
Only
question.
that
What's the most common question you get? Maybe that would be a good question to ask to wrap this up.
One of the most common
check?
questions I get
Yeah.
is, what would you do if this were your child?
Oh, of course.
And
yeah.
when I was younger in my career, I was uncertain what to say. And as I've gotten older, and I've seen enough children have different forms of treatment, I feel much more confident being able to say what I would want to have happen to my own child. And I think that's a really great bonus to have here in the community. The three of us and our nurse practitioners have great experience, and we've all been doing this for well over 10 years. And so now that's an easier conversation to say, this is what I would do if I were in your shoes.
Well, El Paso's very lucky to have both of you all, and thank you for coming. And then we're going to figure out what your favorite Mexican food restaurants are coming up in the next year or so, and then trying to make food on your own, which is kind of fun. I want to say thank you so much to El Paso Children's Hospital, again, for being on the forefront of bringing in different pediatric specialists. That's been really great. We've been talking to Dr. Marcella Woiczik, and again, I have to spell your name out loud again because I just love it. Woiczzik. Love it. And then Dr. John Heflin. So Dr. Heflin is specializing, again, board certified in pediatric orthopedic surgeon and spine specialist. And also Dr. Woiczik, board certified pediatric orthopedic surgeon and hip specialist, but also we're talking a lot about feet as well. If you tuned in a little bit late, or if you want to watch this program again, or really any program that the El Paso Physician has put on, you can do that in several different places. You can do that at kcostv.org or pbselpaso.org, and just look local programs and find the El Paso Physician. Also, the El Paso County Medical Society website, and that is epcms.com, and then also youtube.com. You can just type in literally the El Paso Physician, and usually on YouTube, the search engine will bring whatever the latest show is that we've done. But if there's a program that you wanted to see that we did a couple of weeks ago, a couple of months ago, just type that in there and you can see it there as well. This has been Pediatric Orthopedic Surgery, and this is the El Paso Physician. I'm Catherine Berg, and good night.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.